Welcome to State of Reform's virtual series, 5 Slides We're Discussing, with some of healthcare's most thoughtful leaders. And now, the host of State of Reform, DJ Wilson.
Hello and welcome to another edition of our 5 Slides We're Discussing series. I am so excited you're here with us today. My name is DJ Wilson, one of the folks here working at State of Reform to try to provide these opportunities to have conversations, build relationship, and try to use those conversations and relationships to tackle some of the hardest challenges in healthcare and in our public policy space as well. So today's conversation is a great one. It fits right in that vein and trying to figure out and think through and tackle this sort of migration to value-based payment and methodology, this kind of creature like Sasquatch that we hear something about all the time, but hard to find out in the wild, much less in the city, so to speak. But we've got some good conversations and some interesting anecdotes, qualitative and quantitative conversations teed up for us here today. These conversations are made possible because we have some fabulous, great partners who really align with us in terms of our values and who put wind in our sails to help bring these conversations to everybody, during this time of COVID, but also after COVID as we sort of move into this new normal. And so we're super excited and appreciative of those folks. Some of the underwriters of today's show is Community Health Plan of Washington, a long-time 20-plus year plan built on the Community Health Center network here in Washington State. We also have Kaiser Permanente of Washington, the organization here that has come in and set down roots and started to expand and change the nature of value here in Washington State. And Signify Health, one of our speakers today with Signify Health, they're a national organization working here locally that puts real infrastructure and, as I say, wind in the sails of the move to value. So we're super excited to have those folks help underwrite this conversation with us all today. So without further ado, I want to jump right into our introductions of our panel today. We got some really good ones. And first is, of course, the inimitable Dr. Judy Zerzan, the Chief Medical Officer at the Healthcare Authority. We also have Mark Rothman, Dr. also Mark Rothman. I should say Dr. Judy Zerzan. I'm not sure I got the doctor in there. But Mark is the Chief Medical Officer at Signify Health. And Max Holfert is the Director of Provider Partnership Innovations at Regents Blue Shield here in Washington State. So thank you guys all for being here. We're going to jump into the slides that we have here in a second, but first, Judy, why don't you just tell us a little bit about the work that you do and what is occupying your mental energy these days at the Healthcare Authority?
Sure. So the Healthcare Authority, as probably most of you know, covers Medicaid, state employees, teachers, and retirees. So right now that's about over 2 million people. And we have a lot of exciting things going on. I would say probably the 2 biggest things occupying my time right now are COVID, sadly still, and also some work on primary care and how we improve that. We have a great multi-payer collaborative going on to try and improve primary care in Washington State. So that's exciting.
Yeah, good. Mark, how about you? Tell us about the work you're doing at Signify and what's occupying your mental energy these days.
Well, first of all, it's good to be on with Judy and Max and yourself. Signify is definitely proud to sponsor some of these events, so thanks for letting us participate. I have to confess, just like Judy, COVID still takes up a good amount of my time on a weekly basis. I joke, unfortunately, I have a morbid morning coffee tradition, which is I check the case counts and I check the hospitalization counts and I think about how to keep our providers and our members and patients safe. But beyond COVID, really the thing that we're most excited about is helping to bring value-based payment and arrangements to members of the community up in Washington and Oregon through some of the organizations that are on the call today, and bringing some of our expertise and what we've learned through things like BPCIA and episodic care over to other venues, whether that's accountable care organizations, commercial payers, state-based providers. So that's really exciting stuff, and it's happening across the country. So someday I'll be back on planes and communicating with all kinds of folks, hopefully, who are on this call.
And Max, tell us about the work that you lead at Regents, and again, what occupies or what commands your mental energy these days.
Yeah, thanks. So the work that I lead at Regents is really focused on the Episodes of Care program, which is one of our value-based arrangements that we've put in place over the last couple of years. And I've led the design of it and the implementation of it, and now the launch of it. And as we continue to evolve it and continue to kind of innovate from the foundation that we've built with our procedural program, that's what eats up my work energy at or beyond 100%, which is good, and it's a lot of really fun work, and I think we're making a big difference. Most of my energy, honestly, is eaten up by. I'm lucky to have three really vibrant young children, and that's every other ounce of energy that I've got to give.
As another dad of three children, I can relate, indeed. So let's jump right into it. The nature and the framework of our conversation today is that you all have each brought a slide that is, as I have been saying, commanding your attention that you want to talk about. I've brought two additional slides, one to start us and one to end us. And folks in the audience, you are invited to engage. This will be a fast-paced conversation, but as you post your questions in the chat box here on the right, you can then upvote those by clicking on the little thumbs up icon. That way I will know the questions that have the most demand. And I know that a number of you, we can see this in our analytics, a number of you will listen in and then have this playing in the background. I'd encourage you to come back in and make sure that you can at least upvote those questions and pose a question so that we can see that and then go back to answering email or whatever it is that you might be doing through the show. So without further ado, let's jump right into the first slide. Again, this is one that I brought to the conversation. And this is essentially this is one roadmap of many. We'll see another one here shortly, moving us from the world of fee-for-service into the world of value. And there are a lot of steps along the way. A lot of different entities, Institute of Medicine and others have these value-based roadmaps. And so how different, my question to you all is, as you look at this, how different are we as a sector today when you look at this versus 20 years ago when we were talking about value-based care, and we've been talking about it a long time. We have made some progress, but overall, are you excited, Judy, when you look at this, or do you feel like this could have been 20 years ago, or it could have been yesterday, and that we've been looking at it for a long time? What do you think?
I'm excited about this framework, and HCA uses this framework as measuring its VBP goals. We've picked 2C and on, so it's helpful, I think, to look at this slide and kind of think about that. I think we for sure made progress in this, but it's still kind of slow. There's a lot of fee-for-service in the system, and that used to be where most healthcare was. I think we've made some advances in getting towards bundles and getting towards different kinds of risk sharing and contracts. But I do think we have a ways more to go, and COVID's really brought some, I think, opportunities and complications to that.
So Max, how certainly part of Regents' work with the Healthcare Authority has been catalyzing some of this work. How do you think about, as a health plan, bringing providers along this continuum? How do you kind of develop their confidence, their cultural willingness, and their ability to be successful in a value-based payment world?
Yeah, I think it really comes through our commitment to engage with our providers, to first align incentives with them through one of these value-based payment models. And once you've seen one value-based payment model, you've really seen one value-based payment model. And then to really work with all of our providers, not just those that are in those arrangements, but to work with them to be able to understand what value is, how we're going to be able to work together to drive to delivering better value. And not overwhelming them, but finding that balance between supporting their financial alignment within these programs, and understanding where and how we can find the boundaries to push on to drive better quality and outcomes, and ultimately a better better patient, human, and user experience. Yeah, it's a lot.
Yeah. Mark, I feel like in healthcare we have, this is a reference that maybe only I will get, but the old Prairie Home Companion radio show, we have this Lake Wobegon effect in healthcare where we're all above average. You get to look at a lot of different states, a lot of different, Signify, of course, works in a lot of states across the country. How does the Northwest, how does Washington State compare in terms of its cultural engagement moving down this pathway? How do we compare to other states in the country in terms of our willingness to engage in this conversation?
So there's a lot of variability. You're completely right. Nationally, in my previous roles, I also got to look nationally at provider organizations. And I used to sort of take the pulse in my own mind of where people were along this rubric, right? And one thing I would like to say, though, to the question you asked, Judy, I do think we've come a long way in 20 years. I really do. I think two points I'd make about that. One is that at the very beginning of this journey, you used to see a lot of very staunch non-adopters, right? So to your point, you'd sit down with folks out west and say, where are you thinking your mind about this journey? And they'd say, we're really, cautiously optimistic. We want to engage. We have some history of doing that through managed care structures out west. Then you go into another state and you'd meet providers and you'd say, what do you think? Both at the hospital and the practitioner level. And they would say, this is a fad. We're going to wait it out. We don't want to even do 1% value-based. We're going to go fee for service and see what really happens. And I think the non-adopters are fading away, right? Even in states that are not where the Pacific Northwest is on average, are saying it's time to engage, right? Value-based care is not going away. I can't hold out forever. And to Max's point, I need partnership. I need alignment. I need to at least get a little messy, get a little dirty in this space. So I think that's one thing. The non-adopters are going away. There were much fewer non-adopters out west than there were nationally, even 10 years ago. I think the other thing that I would say is that along this journey, maybe I'm being a little too physician-centric, but we've got a full generation or so of medical school and nursing school graduates who have had to appreciate value-based care. The idea that you'll be judged on quality, the idea that there are metrics that will trigger payment incentives, they're hearing that over their entire education. And I think from a generational perspective, you're going to see a workforce that's just much more willing to engage this and just assume it's a given than you ever saw 10, 20 years ago. So I'm pretty optimistic, but there's still a lot of variability. And it's not only at the state or regional level, by the way. There are cities, there are MSAs in parts of the country where locally there's a lot of variation as to how much fee for service versus value they even want to talk about.
Yeah, to explain my Lake Wobegon effect, it feels like that Washington State and the Northwest is a little bit above average in terms of its engagement, in terms of its willingness to move down the road on value. Is that your take as well?
It is. A lot of the West Coast, and I do credit some of the early, I'm a former Permanente physician, so I do credit some of the early visibility around risk-based practitioners, risk-based provider organizations in that part of the country, and as well as the state agencies who have pushed on this from a much more aggressive perspective than a lot of other states. So yeah, I do see that. There are other pockets that are very, very progressive, but the West stands out in my mind.
I want to move now to our second slide, and this slide comes from Judy. So Judy, why don't you walk us through what you've brought to the conversation?
Sure. So the Healthcare Authority spends about $12 billion on healthcare, which is a decent chunk, and we are committed to value-based care. And that really started in 2015 with our State Innovation Model Grant, and you can see the goals that we set for each year of what percent of our contracts in Medicaid, in PEB, which is the public employees, and we've added in SEB, which is the school employees. And we put some of these goals into our contracts to encourage adoption of VBP. And I think as you can see, we've had some success at that, especially initially. We've recently updated our goals to include that VBP should really include consideration and action on health equity and moving the needle on that. And also that VBP should include whole person care. And so really thinking not only about physical health, but also behavioral health and how that might fit into this. And we have been working on getting there through a number of ways. I think the HCP land framework shows there are a number of ways to do this, but bundles is one way. Our joint replacement bundle has been around for a number of years now and is quite successful. Risk sharing, for that, I want to highlight a contract we have with AbbVie. So the pharmaceutical company is slightly at risk on our Hep C purchasing that I think is a bit novel and interesting. And then global payments or capitated payments. And we're looking at that for our primary care reform and some of our rural healthcare support.
So Judy, how do you see and think of your health plan partners in Medicaid, but also in PEB and SEB? How do you think of your health plan partners in terms of moving the broader system down this pathway towards value?
So we've put in some financial incentives, so that helps. But I also think that that isn't the complete picture. And I think largely most of them are interested in doing this. I mean, I do think in the last 20 years, the conversation has evolved and people really do want to figure out how do we improve the health of a population and how can we do that more effectively and more efficiently. So I think that's helpful. That being said, I do think there are a number of barriers. You can see that our actual VBP attainment has dropped off a fair bit, and I think there are some difficulties in getting there too that are harder for us to incentivize.
So Max, how do you think about being a partner to the state at Regents? So in particular, so that you can tackle that kind of last mile problem, meaning the early adopters are easier than the late adopters, and sometimes culturally the folks at the end of the curve are just really, really difficult to move towards value. So how do you think about trying to help the healthcare authority meet that last mile challenge?
Yeah, I mean, I think about the healthcare authority trying to help us meet the last mile challenge, and that we have a limited capacity to engage our network providers in these value-based arrangements. And the big elephant in the room is a group the size of the healthcare authority. Like if we can bring commitment and alignment with an employer group to be able to that's how we can get the late majority and the laggard adopters in the provider landscape. How we can get them, because we can say, hey, you should join this value-based arrangement, and it's kind of it really needs their internal commitment coming into that conversation. But if we throw a big group and the power and the girth of the healthcare authority and our large employer groups at this sort of aligned commitment, it's a crucial piece of the puzzle. It's not just a nice to have, it's the way that we're going to be able to go the last mile to drive to better value-based arrangements and better outcomes.
Mark, Grayson Miller has this question that fits this roadmap framework, where Grayson asks, how has the COVID pandemic impacted the work in this space? Has payment reform taken on greater importance, or has the pandemic put this work on the back burner as more pressing matters have emerged? What is your sense of that across the country, but also in Washington State?
It's a great question. And part of the answer just comes from our own experience, to be honest with you. As we went out to engage our partners nationwide around extending another several years of bundled payment, right? BPCIA, episodic payment under CMMI, we were concerned that we would find people too distracted, too inundated with fears about their financial situation to engage and even expand. And it was the opposite. What we found was that the incredible unpredictability of COVID, where revenues dropped off a cliff, where what your internal billings might look like 3, 6, 9, 12 months from now, actually really drove a lot more interest in value-based arrangements, because part of that is the potential to have more predictable returns. In some capacities, things like direct contracting coming, things like our employer-based plans where you actually have the potential for capitated payments, so more regular revenue, and also being able to build value into what you do, not just volume, actually resulted in them stepping forward and enlarging the size of the risk pool they were willing to take for BPCIA. Not every client, but a lot. And that really gave me a lot of hope that the COVID experience would actually drive more people to value as opposed to scare people away. Clearly, though, what we saw was they need support, right? To Max's comment, they need the data, right? They need the analytical prowess to be able to predict some of these things 1, 2, and 3 years in advance. They need some guaranteed potential for upside and some protection perhaps on the downside. So complicated, but I do not see COVID stopping the rush to value at all.
So Judy, how do you move folks? There's this old line, I can't remember it exactly, but I'll paraphrase it. It's awfully hard to convince somebody of something when their paycheck depends on them not doing it. And I wonder, to what extent does the healthcare authority or does the Washington State healthcare marketplace, not the exchange, but just the market, need direction from the legislature, compulsion from the legislature to act? We're seeing that a little bit in the Cascade Care public option conversation. Representative Eileen Cody has long said that the only way you make for the most part, the best way to make the market move is to pass a law. As Chief Medical Officer at the Healthcare Authority, what are your thoughts on that question?
Yeah, I mean, of course, the legislature has a role, and I think they can sort of nudge things along, and they have in some ways that has been very helpful, because their interest is really on how do we make our population healthier and how do we bend some of that cost curve growth. I don't know, to sort of a Mark's question about how COVID's enabled this. I think for a long time, and maybe even for as long as 20 years, providers have had sort of one foot on the dock of usual way of doing things and one foot on the VBP boat. And initially, it looked like COVID totally sunk that dock. And so providers were very interested in moving towards something more predictable and that could sustain without in-person visits. I think as COVID's gone on and as we've learned telemedicine techniques and kind of other ways of connecting with people, turns out that usual care dock hasn't sunk all the way. It just has a couple inches of water on it. And so I think we're going to have to figure out, like, can we really get all the way in the boat, and how do we help providers get there? And I think for both providers and for plans or employers, some of the barriers of getting there are the same. So that data piece is really important. And I think there's not a lot of interoperable data. And that's definitely something the legislature could help enable, and has done some things this session around behavioral health data, and thinking about that. And then trying to figure out how to make the incentives and the contract requirements, particularly across multiple payers, multiple employers, really aligned so that it's clear for the provider groups what they need to do to be successful and make this work.
Let's turn now to our next slide, our third slide. And I believe, Mark, this one has your name on it.
Fantastic. And I think some of the questions you've asked about how to get provider groups on board, how to reach out maybe to those original detractors who were holding out, this speaks to that. And when we go out to networks of practitioners and try to get them to buy in to value-based purchasing arrangements through large organizations, either employers or state-based organizations like HCA, we're really trying to show them that they can align and benefit by doing the right thing for patients and recouping some of that value for themselves. And we know that there is so much variability in the system. And that even though we've done a lot of great work on the procedural side, right? So BPCIA is a good example of that. A lot of the variation inside repetitive surgeries or standard surgeries has been wrung out to a fair degree. On the chronic disease side, the variability is still very wide. So reducing variability, which I believe the practitioner groups know how to do if they set their mind to it, if they have the right data and have some of the support systems, they know how to do that, to my comments before. They understand the need to reduce unnecessary utilization. They know that their patients don't want to keep going to the ER if they don't have to, don't want to be readmitted 1 out of 5 times if they don't have to. And we now know that there are a lot of downstream adverse events and unnecessary events that happen, and a lot of unnecessary provision of services. And that's all been pretty well laid out in the evidence, in the literature, and by the specialty societies themselves, to be honest, largely adopted by them. So it's not like it's a vortex of unknowns when it comes to treating conditions, chronic conditions that they see every day. So what I'm sort of demonstrating here and showing here is that if you bucket these services through things like emergency room visits, inpatient stays, pharmacy services on the commercial side, I don't really have all the Part D data on the Medicare side, which is why there's such a big delta there. And these are obviously for illustrative purposes. Only if you can reduce the exorbitant spend on unnecessary duplicative services, if you can reduce ER visitation and reduce inpatient spend and a piece of the pharmacy through better adherence, where can those savings be recouped? They can be recouped in the practice. You can be the ones driving that through additional engagement in your offices. You can be avoiding leakage to other parts of the healthcare system. And then you can figure out what the gain sharing agreements need to look like. And there is enough room in there to offer a discount to whoever the payer is and still increase retention of funds in your practices. I mean, that's really the take-home message here. Now, we appreciate that the practitioners don't all have the infrastructure to do all these things. They don't have tons of extra FTEs necessarily sitting around. And that's where we come in, right? Bringing that data, bringing the analytics, bringing the care planning and the pathways and protocols, bringing some of the technology. And then most importantly, I think, showing them how it's happening in real time. I think one of the big things we haven't talked about, the big innovations that's really going to be key for value, is to get away from the 6 to 9 month retrospective view of how the spending in the care went and become much more prospective, or at least closer to real time in an analytical way, so that practitioners can see what's actually happening to their patients from a utilization perspective, a quality perspective, an adverse event perspective, and ultimately cost. And see how the management is improving over time. That's a tough lift, right? That requires some infrastructure, that requires additional resources and help, which we're working on providing. But once we're there, I really think practitioners will be able to bite on it. We've seen a lot of enthusiasm in lots of different parts of the country for this on both sides. So hopefully that is useful to look at in a visual way.
So Max, as you are working with providers at Regents, one thing this I think highlights is sometimes focusing on episodes of care, specific disease states, or specific time-sensitive experiences like maternity and delivery. Sometimes that's the way to move incrementally towards a model of value-based care. Others would say it's too hard to have one foot in one canoe and another foot in another canoe, that it's better to move farther, faster if you can. What is your experience at Regents about how to work with providers on this question? Faster, more quickly, or incrementally and show progress?
Yeah, I think it sounds good in in a soundbite to say that we're going to dump all the milk on the table and just do it all right now. But I think the reality, as we've seen over however many years now, is that we're eating an elephant, and we're going to have to do it one bite at a time here. And as we implement a program like our episodes of care procedural program, which still rides on the fee-for-service chassis, that's a great first step. And then to get to the next step is going to still probably have a foot on the fee-for-service chassis, being the chronic condition episode program, where it's still based on fee-for-service claims paid, but the incentives that matter are being shifted now slightly further away from fee-for-service. Where a provider is going to have more incentive to avoid the surgery itself. I guess my answer is that my perspective at one level is let's just do it. Let's just flip everybody to full risk right now. But the reality in the marketplace, some markets are different, granted. Some payers are able to just say dance, and all the providers have to do what they say. We don't have that. We don't have that luxury, and as a result of that, we've it's driven more kind of more of an astute approach, frankly, that we have to be very thoughtful about how we're driving that pathway towards shifting accountability to providers.
Let's jump in on our next slide here. This is one that you've brought, Max. So walk us through what you got up on the screen.
Say it here and run out of time. In my mind, the most important point is that to drive real lasting change in the way that we deliver healthcare towards that deeper value that we've talked about, which is really bending the cost curve while producing better outcomes and experiences for patients, is it's going to take alignment, and it's going to take commitment, and it's going to take a village to commit and align on how we're consistently defining value together, which there are a lot of different rules to this game that we're playing, and that's only causing frustration for everybody and slowing everybody slowing everybody down on this path to value. For purchasers, both for at-risk employers and insurers for our fully insured and MA business, and for health plans, specifically the kind of network management and operation function of the health plan, and for providers who are actually delivering the care. All of those stakeholders really need to come together and to align on what it is that we mean by value, and to just be really, really crystal clear on that. So as the network management function of a health plan, how should we compete? Should it be based on black boxes and proprietary rule sets, or should we be working to differentiate ourselves as being able to better support our network in delivering those outcomes and that value that we are coming together to align on how it's defined? And our commitment at Regence is really first and foremost to make healthcare simpler, better, and more affordable for all the people that we serve. Our customers, and the most important contingency of that customer bucket is our members. Those are the humans that are actually receiving the care at the end of the day. And let's not forget that that's what the healthcare industry and all the things we do on a day-to-day basis are really all about. It's easy to lose sight of that sometimes in the minutia of our day-to-day. So network management at Regence, how do we deliver on that North Star of supporting better whole person care? First, we align incentives with our providers on value, often through value-based payment models, and we partner deeply with them to help them succeed in delivering that care. And then we do whatever we can to lower any barriers that exist, administrative or otherwise, and limiting our providers from delivering that great care. I think, prior authorizations, data interoperability, et cetera, et cetera. So historically, our portfolio of value-based arrangements has been pretty heavily weighted on kind of the left side of that land framework that we referred to. And commercial VBA, commercial value-based arrangement activity in general, is traditionally most focused on population health risk and is often pushed to primary care. But one of the many things I've learned in the last couple of years from my actuarial partners is that asking a primary care organization to assume some downside risk, to assume any downside risk, or to assume downside risk for a population when their scope of influence is quite often limited on the specialty and the hospital admit side in particular, is not actuarially advisable. So that's kind of that, and the partnership with the drive, the nudge from the healthcare authority specifically, that they wanted a payer partner who was going to be able to deliver on capabilities around bundled payments and episodes of care, not in a prescriptive fashion, but in the contract we got into with them, they noted that, and so that's really what kind of got this program off the ground. That was a key driver of it, but we developed this episodes of care program in partnership with Signify Health. Took a long time to decide on that partner and decide on the program to really first engage our network that was delivering specialty care with our procedural program, focusing on, like Mark said, on all the actionable variation across the key levers of care. And this is what we've launched, and we're seeing really great early results from in Washington. And now we're in the process of expanding that program to the rest of the region's footprint. And we're also in the process of implementing our chronic condition program, which I'm really excited about, and is a much more innovative evolution of an episodic payment program. And it gets more to the core of aligning incentives away from fee for service, like I mentioned. And then we're working to drive that deep alignment around how we define value with all the stakeholders, so that we can really highlight and differentiate providers that are delivering on that value that we all collectively agree on is what value is. And then to ultimately to ease the path of the patient's healthcare journey to be less complex, to help them have a voice and to have some agency in finding, the right care for their healthcare needs at the right time in the right setting. And that's, once we bring all those elements together, I think that's when the program is really going to sing to its full extent, from which I understand right now, which I think, we're going to keep learning every day as we're on this path together.
So Judy, as you think about this slide and the work Regents is doing in its partnership with the Healthcare Authority, Weilin Huang has this question. She says that Michael Chernow just published an opinion piece today in JAMA where he proposed adopting a portfolio paradigm where, quote, a limited number of models are implemented that work together to achieve overarching goals, end quote, instead of, quote, a garden approach, end quote, of letting multiple flowers bloom to really drive alignment. I haven't read that article. I don't imagine that you have read that article. I think this question is asking about how much directive that something like the Healthcare Authority should provide, rather than sort of letting the market produce, as she says, flowers bloom. How do you balance trying to integrate a couple of key partners and then forcing them in a direction to change the market versus letting the market kind of come back and say, here's some really interesting ideas that we think move the ball forward?
Yeah, that's a great question. And I haven't read that article, but I can relate to it in some way. And I think some of what we've done at the Healthcare Authority is to start with that 1,000 flowers blooming. Working with our accountable communities of health, that's an example. We just said, go improve health. And I think as this has evolved, I think alignment is really key, and starting to narrow of here, let's not have 1,000 flowers, let's maybe have 20. And then maybe let's have 10 and they complement each other. I'm sort of making that up, but I do think alignment is really important. And to pull on a little bit of what Max talked about and taking a village, I think that one of the problems clinicians have about taking on these models is that there isn't timely cost data. And so they don't know the cost of different services, specialists, hospitals. And so it's hard to control that and sort of know that if you don't know. And so if there's some alignment on how the data can go, and some alignment on the quality measures are important, I think that helps make it easier. I also think that probably one of the big fears, at least, and I think that it's based in some reality, is that a lot of providers have insufficient patient volume by different payers to really be able to take on clinical risk. And sometimes that's insufficient patient volume on a particular patient population, but sometimes that's, I have this much with this payer, this much with this payer, this much with this one, and how do I align that? And so HCA is really trying to use its muscle here with our managed care organizations and with our PEB and SEB plans to how do we align some of that to make it easier? And I think we need to keep moving in that direction as a market of how can we have some alignment, because that will help all of us get to really where we want to be, both patients in the kind of care that they want, clinicians and how they want to deliver care, and then employers and payers in bending the cost curve.
So Mark, let me ask about this notion of capitation. I know we've talked a lot about primarily upside risk and limited downside risk. Max talked about how in some cases, for instance, a global capitation model, that may not be great to shift all financial risk to a provider group, particularly if it's a non-hospital provider group. But in terms of a primary care capitation model where a primary care group, maybe a rural health clinic or something like an FQHC, where they can in a given area take on a capitated model just for a narrow set of services. Does that have value in this kind of pathway forward, or does that sort of cleave out the kind of episodic care model that we've been talking so much about?
It's a good question. I think the way that I would think about it, and this goes partially to what I think Judy was just talking about, and your question to her about, let them all be different or let them be similar. When we think about applying episodic, what I call architecture, to procedures, to chronic disease states, really the goal there is to try to align primary care practitioners with specialists, because so much of chronic disease is really non-procedural, but often matures into being procedural, right? So you go from managing a chronic disease for 18 months to 22, 26 months, and then you need procedures, you need specialists, you need surgeons, and you often need facilities over that long journey. And so really what our episodic models are, which we can then nest together with them, so we can sort of have, we can have the chronic disease episode mixed together with the shorter time frame procedural episode and have those providers coordinating and communicating. Really the goal there is to align them so that you don't end up in a situation where, like Max was talking about, you have primary care practitioners with razor thin margins, no procedures, no inpatient services to fall back on, taking downside risk for chronic diseases where they're only participating in 30% or 40% of the total expenditure. So moving primary care practitioners to a more capitated model where perhaps there's a bit of a downside risk only really makes sense if you can align them with the specialists together around those chronic disease states longitudinally. It's a very hard lift, to Max's point, to have them take on downside risks with or without capitation for chronic disease that they're not managing alone.
Yeah. I want to look at our final slide here, which is one that I've brought into the mix. You can tell because it's simple and not terribly sophisticated. But this fifth slide is just an image of the old tortoise and the hare. And of course, that allegory is one where the hare is faster, and yet the tortoise at the slow plodding pace wins the race. And I'm reminded of the adage that if you want to go fast, go alone, but if you want to go far, you need to go together. So I'm wondering if the lesson here that we are taking from our conversation is that it is better to make sure we move incrementally, make sure we bring along culture, make sure we bring along systems, make sure we bring along a broad base of folks. How do we as a community, as a sector, hold each other accountable to make sure that if we are plodding and going slowly for all the right reasons, that we continue going and that we actually finish the race? Any of you have thoughts on how we can hold each other mutually accountable to get towards this goal that we've been talking about for so long?
So I'll start with our primary care work that HCA is leading here in Washington, because we sort of have three legs of a stool. We have the multi-payer table that has payers in Washington that are committed to primary care and working together. We have a clinician table that is clinicians and health systems that are primary care providers and trying to push it forward. And then we also have a group of employers led by PBGH and the Washington Health Alliance with their interest in primary care. And they've made public a letter, number of employers signing, saying that. And I think it takes all three of those to sort of put pressure on each other and keep things going in the right direction. And when you don't have that alignment or sort of that mutual symbiotic relationship, maybe it's super easy to say, well, it's their fault. I'm doing everything I can, but these other two groups, whichever other two groups they are, they're not doing their job. And you got to do that first. And so I think the power, I hope, of our primary care work here in Washington is that we have all three of those groups at the table, sort of pushing on each other. And I think the one group that is potentially missing from that is ultimately important is the patient, or the actual people getting the care. And so I think that is one piece that I would love to sort of help push on, is how do we, people who want to get good primary care, who are interested in getting care in different ways, how do we help them have a voice at the table? And how do we help the public sort of push on this together so that we're all moving in the same direction? And that, I think, is really the path forward.
Max, Mark, you want to jump in on this question of mutual accountability, or perhaps the patient's role in all of this?
Sure, I'm happy to, or Mark. I'll just kind of piggyback on what Judy said a little bit at the end there. That that what we're currently doing, the phase that we're at, and the phase that I'm at, and the phase that our group at Regents is at, is still very much focused on aligning those financial incentives with the providers, and that is the foundation that we need to do, and that's where we should be, and then supporting those providers to succeed and holding them accountable to both cost and quality, and being really clear and transparent about what that means. But what we do need to level up to is, okay, so once that value is defined, how are we going to support patients to have that kind of that agency within their healthcare experience, and how are we going to give them the actionable information that they need to make decisions for their health that have both cost and quality implications, and and then how are we going to holding each other accountable? I mean, it's all about partnership, and I know that sounds kind of cliche, but it is. Like, it's not, like, for instance, I look at our relationship with Signify. Signify takes deep accountability with Regents through this program. They are our program partner. If the program doesn't succeed, they don't succeed. And any opportunity we have to align accountability between the key stakeholders, and to do so in a transparent fashion, I mean, I think those are the keys. And I know I'm kind of kicking a horse here, but that really is the key: the transparent, consistent definition of how we're defining value. And then that's, once we align those incentives, primarily financial incentives, but they're, once we say it out loud, we're creating social incentives, and we're creating moral incentives that we believe this is the right thing to do, and we're all committed to doing it together. Yeah, sorry, kind of preachy there.
No, that's okay. And I'm going to ask a slightly different question, Mark, if I may, which is building on Max's comment about the sort of social element. It does seem like if we want to make sure that we are getting as upstream as possible to mitigate things like complications from diabetes, that does begin to spill into social determinants. And so I'm wondering about how you think about social determinants as a piece of an episodic or bundled payment methodology. What are your thoughts?
Well, first of all, I want to thank Max, obviously, for his thoughts about Signify. I appreciate that. And I just would only have added to those two comments that transparency is just so important, right? Transparency about the variability in pricing, which is good for patients and for the public. Transparency about quality. That's critical. If we're going to hold ourselves to high standards, the standards have to be visible in the marketplace. I really believe in that firmly. And back to my original comments about the generations of healthcare practitioners coming up, I think we're used to that now, right? Enough people have been in an ACO, they've seen their quality scorecards, their pricing scorecards. So I think that's key. To your question about social determinants, we think about this all day long. We lead a team of social care coordinators who are on the phone with patients after going home from a hospital, solving problems for them around transportation, getting to doctor's offices, making sure their utilities are still on and they can afford those bills, food shortages, etc. I really think that until we have taken the social determinants of health and built them into the risk adjustment, there's actually been some nice data and papers published recently about incorporating social determinants into risk adjustment for things like hospitalizations and rehospitalizations and outcomes. Until we've successfully built in the social determinants into that risk adjustment methodology, the definitions of our populations, and we actually put that as part of medical practice, as part of healthcare practice. For those of us who believe it, we're doing it, but not everybody thinks that the social pieces are theirs to engage. I think we're going to have to do that nationwide, especially after the pandemic, which has just exposed such incredible variability in people's social stability. So we're big fans, leaning very hard into social determinants of health, and I think the whole nation is ready for that as well.
So as we get near the end here, I want to ask each of you one final question. I want to just acknowledge Victoria and Grayson, the other questions that I did not integrate into our conversation. I appreciate you posting those. I think we addressed some of those, even if I didn't call them out directly. But let me ask each of you as we wind down, what gives you hope in this space about moving to a value-based payment methodology where care and finances are better aligned? What gives you hope as we sit in May of 2021 and look ahead to the world to come? Judy, what gets you excited and hopeful?
Yes, I think one of the opportunities COVID brought is that we at the Healthcare Authority had been trying to get towards how do we do more than just the in-person, face-to-face visits. And it was super hard to do until the bottom fell out. And we're super excited. There are video visits. It makes care so much easier in many ways. There will always be a place for in-person visits, and we don't want them all by technology. But I think this pandemic has shown us that we can move quickly. It doesn't always have to be slow. And then I guess I'll say sort of in closing, I do like this tortoise and the hare. And I think whichever one we are, we just need to hold hands and start that race. And we got to keep moving, and we got to do it together, because that's how we're going to get there. And I think there's a lot of nice collaboration and working together here in Washington that gives me hope that we'll get to the finish line.
We got to keep moving and do it together. I love it. Max, how about you? What gives you hope for the rest of 2021 and beyond?
I'm generally a very hopeful person. I'll open with, but what really kind of inspires me coming out of the pandemic is that it's kind of a sad note. It is a very sad note, but a lot of deep social inequities have been very exposed coming out of this, and I think that has driven us to have much more frank and honest conversations about, from a perspective of putting together programs like this, the inclusion of a quality metric around healthcare equity. That I don't think that had ever been really seriously considered. Now it's something we're talking about. How can we have equity measures built into how we're thinking about quality? And it's really brought to the fore this patient experience and so because of that, and I think that's accelerated these inequities have accelerated are looking at this as kind of key elements of quality. And so we're looking very closely at how can we incorporate patient-reported outcomes as a part of what we're thinking about quality. It's not just HEDIS measures. Most people don't even know what a HEDIS measure is unless you're in healthcare. But a complication rate, if you get readmitted for a surgery, if you got a functional outcome of getting back to your job, if you felt like you were treated fairly and you felt like you were respected throughout your healthcare journey, if those things can start being incorporated, I've seen a lot of really, really promising momentum in that direction coming out of this. So that's my main kind of thrust of hope right now.
Mark, how about you? Last word. What gives you hope as you look out on healthcare in 2021 and beyond?
Well, aside from all the comments that have been made, which I'll agree with, the move to digital, as a geriatrician, one always feels hopeful that it turns out that older adults can use technology. No problem there. Everybody thought they couldn't, but guess what? They can do virtual visits. So I'm happy about that personally as a geriatrician. But I'll tell you what gives me hope. This is the kickoff for Nurses Week. And I just am incredibly proud of all the things that nurses have done and physicians over the past year. I'm just incredibly proud to be a provider. And I think everyone realizes that you can't be at it alone, right? To the point that Max was making. Practices have realized they've got to form partnerships. That is the key word. And I just see that happening all across the country. So I'm just incredibly excited about that. And the fact that there is an opening for technology in a way that healthcare has never seen before. We'll see how much of that becomes real. We'll see how much of that is paid for or not paid for, and how we afford to get that done, and where the data is all housed. but gosh, the opening that was just created in healthcare for a flood of technology solutions, that also makes me pretty hopeful. So all of those things together.
Mark Rothman, Chief Medical Officer at Signify Health. The inimitable, as I said, Dr. Judy Zerzan, Chief Medical Officer at the Healthcare Authority, and Max Holfert, Program Director of Provider Partnership Innovations at Regions Blue Shield. Thanks, of course, to our underwriters, Kaiser Permanente of Washington, Community Health Plan of Washington, and Signify Health. And to you all for sticking with us and participating. As Mark said, it's kickoff to Nurses Week, which I did not know, but of course we're in May, and I do know that it is Mental Health Month. So get vaccinated, wash your hands, and then give free hugs as often as you can. So thanks for doing this, for supporting us, and we'll have more at stateofreform.com. Thanks, everybody.
Thank you.
Thank you all.